Professor Cross. It's my honor to have today's online communication with you. My name is Ying Xu. I'm a breast surgeon from the Department of Breast Surgery, the first hospital of China Medical University. At this year's ASCO meeting, your research FREGAIN trial has attracted wide attention, I think. It provides a nice way to evaluate early response of neoadjuvant therapy and let some patients who are sensitive to dual HER2 blockade could be chemo-free. I think it's a very exciting result. But for this study, I still have some questions to ask you, if you don't mind.
Sure.
Okay. I remember previous literature showed the metabolic change in breast tumor could be detected as early as 2 weeks after beginning anti-HER2 therapy. And in TBCRC 026 trial, the PET evaluation was performed at 15 days after trastuzumab and pertuzumab. But in your study, PET scan was gave after 2 cycles of dual HER2 blockade, about 6 weeks. So why do you choose this time point? In your opinion, which is the best time point? Thank you.
So first of all, thank you so much for the interest in this study and also for giving me the opportunity to discuss with you and to give my personal thoughts or personal comments about this project. As you very nicely mentioned before, this is a study to try to de-escalate chemotherapy for those patients with HER2 positive early breast cancer. And the basic idea of this project is to try to develop a strategy-based study, which means that for all patients with this disease, we will try to start with anti-HER2 therapy only, without chemotherapy, and depending on the PET scan and depending on the pathological complete remission, the patients will receive or not chemotherapy. And if we are able to observe a similar invasive disease-free survival than expected, then we will be able to de-escalate treatment. So the question you raised before, I think is important. We had, and you are completely right, we had preliminary reports showing that PET scan or MRI after very early on time, 2 weeks, 2 to 3 weeks, we can, predict which patients will have a pathological complete remission. And this is right. So why did we decide to go for 2 cycles, which is in general about 5 to 6 weeks? Well, it was a little bit arbitrary, but it is true that we wanted to try to have the maximum value of the PET scan. So imagine, and it is true that after 2 weeks could be very good, but imagine that there are some patients that maybe will respond after 4 or 5 weeks. We just wanted to be sure that nobody who could have benefit from the strategy will not have it. That's why we decided to go a little bit more and go for 5 to 6 weeks instead of 2 weeks. But it's true that maybe in 2 weeks could we have enough.
Oh, thank you. So in your study, so the treatment stages were adjusted by PET response or not. So what is the definition of PET response? You use the persistent creation or other cutoff. What is the optimal PET cutoff as UV max for PCR?
That's a lovely question. Yeah. And the honest answer is we do not know which is the optimal cutoff by PET.
Yeah.
Okay? But it is true that there are some data in the literature showing that a response and reduction in the SUV of 40% or more is good enough to consider a response by PET. Is the optimal cutoff? This is something we are trying to also analyze in this study if we can define a better cutoff, but the literature says that 40% reduction is considered a good response by PET.
Okay, I think it is the second primary endpoint of your study, right?
So the primary endpoint of that, we have two co-primary endpoints, but one of them is patients who achieve pathological complete response between those patients who achieve a PET response.
Oh, thank you. So definitely PET-CT is a more accurate assessment. However, in our country, especially in a lot of places in China, due to the economic or medical resource or other factors, ultrasound and MRI are the most commonly used to assess during the neoadjuvant therapy. So do you think we could use these ways instead of PET-CT to guide treatment adjustment?
Well, first of all, I do not know if we can use PET scan to do that. We should remember that we need the second co-primary endpoint, which is the most important one, which is long-term outcomes, to see if this strategy works. So if this strategy works, which means, once again, PET response, no chemo, pathological complete response, no chemo. So if this strategy works, I think that in the future we have to discuss about further strategies with cheaper assessments, such as ultrasound or MRI. The point with the PET scan is that with the data we have today, it correlates very nicely with PCR. Moreover, in our study, which I think is something very, very remarkable, I would say, for those patients who achieve this PET response, a significant number of patients did have pathological complete response, 37.9, almost 38%, which is a very impressive number. So can we achieve these numbers with MRI, with ultrasound? Well, this is not very well known, but with PET, it's clearly something of interest. In the future, if we demonstrate that this works, it's much cheaper to go for PET scan twice, but decrease the chemotherapeutic agents in maybe 1 out of 3 patients.
Okay, so you will wait for the survival data, right?
The disease-free survival data, correct.
I think the primary endpoint is 3 years invasive-free survival, right? So correct. You will wait that data to see if the response cutoff is the best one, right? And we can use the PET-CT to do the prediction, right?
That is totally right. Exactly. So we will wait to have these results, and if we have the results we might expect, then we will say, listen, let's start with a PET scan, response, PCR, and depending on that, we will give or not chemotherapy.
Okay. I think it's a very, very smart design. It's very interesting.
Thank you so much, my friend. I think it's provocative. I think it's quite innovative. But I think that in the future, if we want to de-escalate treatments, this is the type of trials we should conduct, in my opinion.
Yes. So the next one, in your study, I see you collect the tissue and the blood samples at the baseline, the 2 cycles of neoadjuvant therapy and the surgery. So do you think we have other biomarkers could be used to assess early response of neoadjuvant therapy, maybe combination of the imaging and the biomarkers to decide which one is sensitive and which one is not, such as the PRELISA trial after 2 weeks of letrozole, and they do the biopsy. The change of Ki-67 was used to guide treatment next step. Maybe we can make the combination of the imaging and the biomarker.
Sure, no, absolutely, definitely, you are completely right. We will have a blood sample samples, but also tissue samples. So not only Ki67, but also, but tumor infiltrating lymphocytes. Maybe we will try to discuss about the PAM50 platform. So what about HER2-enrich or HER2 or non-HER2-enrich? So we will try to afterwards to build something to define which is the optimal group of patients who will not need chemotherapy.
So now, do you have some interesting result now with the tissue or the blood samples?
We are doing that effort now, and I hope to present maybe some data for San Antonio. I don't know, but at this time, I want to be very honest. We do not have anything yet. So I do not have any data.
I hope you will have good data.
Sure.
And we know there are many factors related to the sensitivity of the anti-HER2 therapy. And your study shows that the PET response were higher in hormone receptor negative and HER2 IHC3+ patients. Are these patients consistent with PCR population?
Okay, so we should not forget something. So in general, who are the patients? Which are the patients that might respond better to the PET scan? Maybe those ones who are going to be more sensitive to anti-HER2 therapies, which are patients with ER positive, HER2 positive. So maybe patients without hormone receptor positivity are the ones who are more likely to respond. However, because of that, many of these patients will receive chemotherapy afterwards. So this is why maybe we can say, listen, in our Arm B, in those patients who receive not chemo treatment at the very beginning, ER positive was not clearly correlated with response. But the answer is very clear, because more patients without or with hormone receptor positive tumors received chemotherapy compared with patients with ER negative tumors. You know, so again, we have to build everything there to understand which is the optimal group of patients who will not need chemotherapy. Probably those ones with ER negative, HER2 3+, the patients with more likely to respond to anti-HER2 therapies, also helping with the addition of the PET.
You know, I remember in Pamela trial, we find that the intrinsic subtype is different with IHC to detect the HER2. For the hormone receptor positive patients, maybe about 40% is a real HER2 enriched patient. But in hormone receptor negative patient, there are about 85% is the HER2 enriched patient and can make sensitive for dual HER2 anti-HER2 therapy. So do you think we can use the intrinsic subtype of PAM50 or the HER2 heterogeneity detection initially? In other words, begin before we do the neoadjuvant therapy will be helpful to develop treatment strategies.
Sure. And this is something we will definitely look at. So again, so I think that HER2-enriched respond better to anti-HER2 therapies. That's very clear. But also, we should not forget, they respond also better to chemotherapy. The point here is, are we able to de-escalate treatments based on the intrinsic subtype? Not today, because we have not done any clinical trial based on this biomarker with an invasive disease-free survival endpoint. So I agree with you that if we integrate all these things, we will be able to optimize which treatment, which patients will not need chemotherapy in the future.
Okay. I have the last question. So in KATHERINE trial, adjuvant treatment with T-DM1 results in a 50% lower risk of recurrence or death than trastuzumab alone among HER2 positive patients who had residual invasive disease after completion of neoadjuvant therapy. But the proportion of the dual HER2 blockade in KATHERINE was less than 20%. So we also know in AFFINITY trial, the trastuzumab and pertuzumab has a good survival data, even in high-risk lymph node positive patients. I see in your study, Arm A, for non-PCR of the dual blockade during the neoadjuvant therapy, you will go on give them the Herceptin, the pertuzumab and trastuzumab to do the adjuvant therapy. So we still have no head-to-head comparison between PH and TDM1 for non-PCR patients, we know. But in your clinical practice, which regimen would you prefer for non-PCR patients with dual HER2 blockade neoadjuvant therapy?
What a beautiful comment. What a beautiful question.
Thank you.
So in my clinical practice, okay, so this was a clinical study. So again, we have to see the results. Although it is true that once Catherine became available, some patients who did not achieve PCR after chemotherapy, Herceptin pertuzumab, we have the dilemma about can we change into TDM1? Okay, and there are some patients, not many. Maybe I don't have the numbers. Maybe 8 to 10 patients who received TDM1. Okay. But in my clinical practice, when I go for chemotherapy, Herceptin and pertuzumab, and we do not achieve PCR, I switch to TDM1. But the question is out of there, and it's a very old question. What is better, to switch into TDM1 or to continue with Herceptin and pertuzumab? So I don't know, but if I can switch, I do it.
So to say, it's my opinion, I think these kind of patients may be two situations. One is near PCR. So the residue disease is about maybe smaller than 1 centimeter. I think it demonstrates the sensitivity of the neoadjuvant treatment of HP. And these patients, maybe we will let them go on dual HER2 blockade adjuvant therapy. Maybe it's fine. And the other is a real non-PCR. The residual disease is much larger. So it may be because of drug resistance. Maybe this kind of patient, we can recommend the TDM1 for adjuvant therapy, is my opinion.
Sure. No, that's, again, a very good point. If we look at Catherine, patients who receive anti-HER2 therapy before surgery, and they have a very good response, but not complete, also benefited from the use of TDM1. But of course, it is not the same. And if we continue with Herceptin pertuzumab, I don't know. Yeah. So it is very reasonable to continue with Herceptin and pertuzumab. But if you are asking me, in my clinical practice, I would prefer to change.
As the Catherine trial.
As the Catherine study, correct.
Okay, thank you. But do you think is the toxicity of TDM1 is much more higher than HP regimen?
Well, HP has diarrhea, which is not an issue without chemotherapy, but could be. TDM1 is harder. It produces more asthenia, of course, thrombocytopenia, transaminitis. I think it is worse compared than Herceptin and pertuzumab. But also, the toxicity profile is very nice with either of these strategies.
Oh, in your clinical practice, the TDM1's safety is fine, right?
Yeah, it is fine. It is fine.
Oh, okay.
It is fine. I prefer Herceptin and pertuzumab, but TDM1 is also very fun, very good.
Okay. Thanks again for solving many of my puzzles. Thank you.
Thank you so much. Thank you.
So, and hope the epidemic will pass soon and we'll have chance to talk face to face.
That would be great. Thank you so much, my friends. And thank you so much again for your interest in the study. Thank you.
Thank you.
The good news, I think this is an excellent comment. The good news is that at least in many countries, Herceptin and pertuzumab are approved in this setting. So this will depend on clinicians. If they feel comfortable and confident on this study and on these results, you can do it in your clinical practice because you do not need anything to be approved. The drugs are there. is just to decrease the use of chemotherapy. It's not to add anything. It's just to decrease chemotherapy. So it will depend, physician by physician, the confidence in the study. But let's see the results, and more than happy to to discuss with you again the data.
我觉得这项研究呢，我觉得是一个特别有意思的研究。其实我们目前呢，HER2阳性早期乳腺癌一直是在致力于为那种更精准的升降阶梯而探索。所以新辅助呢，无疑是这种最佳的指导平台。那么早在像 TBCRC006啊，或者023呐，或者 PAMELA 等一系列 HER2阳性乳腺癌的新辅助研究当中呢，仅应用双靶联合或者是不联合内分泌治疗，就可以获得10%到40%的这种 PCR 率。所以这也提示我们，对一部分对于双靶治疗特别敏感的人群，是可能豁免化疗的人群。但如果我们能够早期的甄别哪些人群是这种敏感人群，就可以在新辅助期间进行一个方案调整，并且呢，获得了完整方案之后的 PCR 或者是难 PCR 的人群，还可以为后续的辅助治疗提供信息。但这种预测工具呢，或者标志物的效能是非常重要的。就像刚才 Carlos 教授所说的，其实他们目前呢，对于 PET-CT 的这个 cutoff 值，还是要等回顾性的来看，等到有了好的生存结果，再往回推来看我这个 cutoff 值选的准不准。但无论如何，我觉得 FORGAIN 研究是给了我们一个很好的思路，它是以这种 PET-CT 作为早期疗效的一个预测工具，并且呢，早期反应型的这种患者当中就有40%的这样 PCR。如果后续 IDFS 也得到不列于化疗联合的这样的结果，就可以做到治疗的一个降阶梯。而且这个研究呢，也提示我们，其实在我们的临床实践当中，我们可以探索一些功能学的影像啊，结合2次穿刺这样的病理的 MP 分级等方式，做一些早期疗效的预测和方案的调整。谢谢。